All right, everybody, here we go with Chapter 9, Speech Sound Disorders in Children. The questions for the chapter: what is a speech sound disorder? How are they classified? How are they identified and described? And how are speech sound disorders treated in evidence-based practice? SSDs become evident during the developmental period for speech sound acquisition, birth through age 9. They're really one of the most prevalent communication impairments among children. So depending on the study, anywhere from 4 to 13% of children have a speech sound disorder. And like, pretty much all disorders in our field and in most fields, it's going to be more common in boys than in girls. Speech sound disorders are an impairment of the sound system resulting in a significant problem with speech sound production that differs from age and culturally based expectations. It arises from either an articulation impairment or a phonological impairment. And let's talk about those for a second. An articulation impairment is an inability to articulate certain speech sounds correctly. And these are thought of as a phonetic impairment. So if a child has a hard time saying his R's or his S sound or L's or individual sounds, that's going to be an articulation impairment. And that's compared to a phonological impairment, which involves the rules that govern sound patterns in a given language. And this is referred to as a phonemic impairment. So if we have a child who doesn't, who stops all of his sounds, do, aw, hib, downed, did, right? I'm stopping everything. I don't have any long sounds. I've just got short sounds. Or maybe I don't have any K's and G's because my tongue's always forward in my mouth and not back in my mouth. And we'll talk about that later. So a phonological impairment really is about, a child not understanding a rule of language, and sort of missing a whole class of sounds. Whereas an articulation impairment is more about, one individual sound or two individual sounds that the child's just not articulating, the way we'd expect him to. All right, the cause, about 60%. The cause is unknown. About 40% of speech sound disorders are attributed to middle ear infections, motor speech disorders, and other developmental disorders. All right, and of course, there's a lot of variation in speech, depending on where people are from as well. So speech variation is differences in speech arising from a dialect or foreign accent, not a speech disorder. Dialect is a speech and language variation characteristic of a group of speakers from a particular region within a country. And foreign accent or language influenced speech is speech in which characteristics are carried over from one language to another. So dialect, you could have a Southern dialect, you could have an African American dialect, you could have, all different kinds of dialects, and it's certainly not a speech disorder. It's just a difference in how words are pronounced. And, certainly that will go along too with a foreign accent. If a family, up here in Boone, we have a lot of families up here from Mexico and Central America. You don't see them necessarily on campus every day, but they're, a lot of the workers around here are from a different country, and so they will have an accent and they're going to pronounce their sounds a little bit differently. Again, certainly not a disorder, just a difference. All right, key concepts. Phonemes IPA, enunciation of English consonants and vowels, and normal acquisition and development of speech sounds. So let's go through these. All right, phonemes. To be considered a phoneme, a speech sound must be able to signal a contrast in meaning between two words of a language. So it's the smallest unit of sound that can affect meaning. So in the word pat versus bat, right? Pat versus bat, right? The only difference is the p and the b, right? So that those two sounds affect meaning. So the p and the b are separate phonemes. Right? Standard American English has about 40 sounds or 40 phonemes that create hundreds of thousands, if not millions of words in our language, only with those 40 sounds. An allophone is a variation of one phoneme. So every time I say a p sound, whether it's in pin or pen or mop or moped or whatever, right? I say it actually a little bit differently. So when I say pin versus I say spin, right? Oh, did you hear that? Pin, spin, right? Those P's are different. They're both the phoneme P, but they're different allophones because, they're pronounced a little bit differently. P, p, pin, spin, spin, p, p, pin, spin. All right, same phoneme P sound, different allophones. All right. And this has to do with two things. One is co-articulation, the way sounds overlap during articulation, causing articulatory characteristics of phonemes to vary according to context, right? So because I had that spin, I had that S sound in front of pin, actually changes how I make that P sound, right? So the sounds in front of and behind that phoneme, that co-articulation changes how I make the P sound. And this has a lot to do with assimilation. The way the features of one sound take on the features of neighboring sounds, all right? Say that final sound in those two words. Dogs, 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 dogs. Cats, 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 cats. Now that's actually two different phonemes. In dogs, 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 I'm making a z sound, z. In cats, I'm making an s sound, right? So I've got two different phonemes because of assimilation. Now, lots of times it just turns into an allophone where it's the same phoneme, but like in pin versus spin, but in the dogs versus cats example, the features of the sounds before actually turn that final sound into two different phonemes. In dogs, the g sound is voiced, dogs, and so the letter S becomes voiced, which makes it a z sound. In cats, the t sound is not voiced, so my S at the end is not voiced either. Dogs, cats. I hope that makes sense. The International Phonetic Alphabet, IPA. So because of that, right, we actually have to have a separate alphabet, the phonetic alphabet, that describes and classifies each speech sound on the basis of how and where it's produced in the speech mechanism. The IPA represents each phoneme used in the world's languages, both vowels and consonants, as specific symbols, right? So depending on the language, right, there are sounds in other languages that don't appear in English. There are sounds in English, most likely R's, L's, and theta sounds that are not used in many of the world's languages. So different languages use different phonemes to make up their words. And the IPA represents every meaningful sound across all languages. And because of that, right, if I could transcribe somebody's speech in French, I wouldn't have to know what any of it meant, but I could actually write down all the sounds using the International Phonetic Alphabet. Likewise, if I have an English speaker who has a speech sound disorder and is very hard to understand, I can use IPA to transcribe exactly what he said, all the sounds he used, even if I couldn't understand any of it. So this is what the sounds are. This is what the way he's saying his sounds. All right, pronunciation of English consonants, how we classify consonants. And lots of times you'll hear just place, manner, voicing. So the place of production, the manner of production, and the voicing goes a long way in how we classify our consonants. Place of production. Where in the vocal tract a sound is produced. All right. Bilabial sounds are produced with both lips. Ooh, ooh. Labiodental sounds are produced with your upper teeth and lower lip. Linguidental, between the teeth. Alveolar, tongue, and alveolar ridge. D. Palatal, tongue and hard palate. Oh. Going further back with our tongue, right? We're kind of started from front to back. Velar, tongue and soft palate. K, g, k, g, k, g. And finally, glottal, right? There's no tongue, there's no lips. It's just glottis. So that opening in your vocal folds is the glottis, right? And so that makes the H sound. H is much more like a vowel than like a consonant, but we call it a consonant. All right, and you can check out that website, and that's part of your homework too, theantimoon.com. So check that out and check out the IPA sounds and how they're written. Manner of production describes how a sound is produced. All right, so this is kind of what I was talking about before. So stops, complete obstruction of vocal tract. T, d, k, g, b. Okay, short, just stop. So stop breathing and then breathe really quick and short. Fricatives, partial obstruction of the vocal tract, right? All right. Affricates, partial obstruction followed by release. Ch, ch. So an affricate's kind of the combination of a stop and a fricative. Nasals, there's only one. Well, actually, that's not true. It's and ing. Oh, and there are three. Velar-pharyngeal port open. Ing. All right, I actually have air going out my nose as well as my mouth. Every other sound is produced by closing the velar-pharyngeal port, only breathing out your mouth while you're talking. Liquids, almost open vocal tract. R, O, R, R. All right. Finally, we've got glides, open tract and gliding tongue. Woo, when, yellow, when, yellow. All right, so glides and liquids are similar, but a little bit different. All right, then we've got voicing. Describes whether or not a sound is produced with vocal fold vibration. So, p, t, k, p, t, k, p, t, k. All right, there's no voicing going on. All right, the next sounds are exactly the same as the others, but the only difference is voicing. B, d, g, b, d, g, b, d, g, right? B and p are exactly the same. They're both stops, b, p, right? They're both bilabials. The only difference is the voicing in b and p. Moving back in our mouth, d and t, exactly the same. D, t, d, t, d, t. Only difference is voicing. Then moving all the way back for velars, g, k, g, k, g, k, exactly the same. The only difference is voicing, and those, that's sort of how we make our sounds. That's how we make our consonants. Vowels are characterized by 4 articulatory features. How high is your tongue? How forward in your mouth or back in your mouth is your tongue, so height and advancement. How round are your lips? And how tense are your lips and your tongue when you make the vowel. So, and most of our clients aren't going to have a hard time with vowels. It's only going to be consonants. So we focus a lot more on consonants than we do on vowels. All right, speech sound acquisition and development. Pre-linguistic period, from birth to 12 months, right? We've got some cueing, we've got babbling, so we've got lots of sounds, lots of vocal play, but we don't have words. Words are going to show up around age 1. My youngest son is almost 10 months, and he's starting to say baba for bottle. So that we think that's his first word. We want to hear it, more often, to make sure he's not just saying ba 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 ba, right, which would be babbling. But he's been pretty consistent with that lately. So, he's a little bit early with his first word, but that's really, anywhere between 10 and 14 months, well within normal range, so, but up until then, up until there's a word, it's pre-linguistic and only cueing, babbling, lots of vocal play. First words are going to show up, like I said, really anything before 18 months. As long as we get the first word in by 18 months, not a big deal. As long as we've got a lot of good cueing and babbling going on, I'm not going to be concerned. But if a child's 18 months and they're still don't have any meaningful words, and again, right, my son said "baba" for bottle. That's really not even close, but he's got the first, the first sound, the first consonant, the first vowel. He's repeating them. And he's using them meaningfully, so that counts as a word, right? If we don't have any meaningful speech by 18 months, I'm going to start to get worried, and that, this might be a child then who, if we didn't have that, would be at risk for a speech and language disorder. Then we've got the phonemic period. So from 18 months to 4 years, we start getting a lot of speech sounds. So we're going to have b, and just a lot of good sounds, maybe certainly d, t. We're going to get lots of good sounds coming in. All right. The final sounds are going to come in between 4 and 7 years. Really, we'll get our final sounds, our final 8 sounds, especially, and we're also really stabilizing. So, right, if we have a kindergartner, if we have a 5-year-old who still doesn't have R's or L's or TH's, thetas, I don't care at all, right? It's not a concern. They're not really supposed to have that till 6 or 6.5. So, right, if we have a child that substitutes W for R and they're, 5 or even 6, it's totally normal, right? It's when we get to age 7, age 8, where you start going, yeah, we really should have this. Don't have it yet, all right? And also, speech should become pretty adult-like during that time. So, the sound should be adult-like, the grammar should be more adult-like, right? Really, between 4 and 8 years, we're going to stabilize our speech and become a fairly adult-like speaker pretty early on. All right, there's also a nice table on page 281 to 282 of your text that really explains a lot of this good stuff. All right, how are speech sound disorders classified? Again, a lot of them have unknown origin, functional disorders. They can be articulatory and phonological difficulties. If we have a known organic origin, that could be because of structural deficits, sensory impairments, or neurological impairments. That could result in a motor speech disorder, right? So a structural deficit, right? If they're born completely deaf, if there's something impacting hearing, if there's something impacting their tongue or the movement of their tongue or something else, right? That's going to be, so that's going to be structural. Sensory, sorry, that's going to be the hearing, right? It's going to be sensory, that I can't hear. I don't know what you're saying. So, right, it's going to be really hard for me to learn speech if I have a hard time hearing what you're saying. And then neurological impairments, if we have Down syndrome, anything like that, right? Any kind of cognitive or other neurological impairment, that's going to be a big risk factor for a speech sound disorder. All right, SLPs use a systematic and comprehensive process of assessment to identify phonological disorders in children. Speech assessment involves careful, informed observations and hypothesis testing. Referrals typically made by a parent or a pediatrician or an early childhood educator will say, speech just isn't where we think it should be. For children under age 2, signs of a possible speech delay may include hearing loss or, well, this goes in hand, chronic ear infections, any known physical impairment, particularly of the oral facial structures. So again, if we, if the person's not able to move their tongue or lips, has a cleft palate, right, something going on, that's going to be a big factor. And any known cognitive impairment as well is going to be certainly a warning sign. Warning signs of speech delay, all right, delay in vocal play, babbling, appearance of first word, and use of two-word combinations, right? So often children with autism, there was sort of this idea that, we can't identify kids with autism until they're older. But if you look back, and people are now starting to study children that are at risk of autism and those who are more likely to develop autism, right? They have delays in babbling, they have delays in their first word. Often kids with autism are really not that interested in making eye contact, not interested in putting two words together, right? They're just not, they're interested in other things. They're not interested in, in talking yet. A limited phonetic inventory, right? So even, so like right now, my son, who's almost 10 months, right? He's got B and G a little bit. As he gets older, every month or every, few months, he's going to add a sound or two. We might have an right? We might have other sounds popping up here soon. Intelligibility of early words to familiar caregivers, less than 50%, right? So if a child's, you can have kids who have a lot of vowels, like that they know what they want to say, that they're saying a word, but it's all vowels. Or maybe they only have one consonant and everything has either a B or a D and a vowel, and there's nothing else. And people are like, I know you're telling me something, but I have no idea what you're telling me, right? So intelligibility is a big issue. And then reliance on gestures, right? If there's a lot of pointing, if there's again, there's vowels that and I'm pointing to things. It's like, okay, I know you're telling me, but we don't have the speech yet. So screening, relatively short assessment of a child's speech to identify whether a child may have a speech delay that requires a full-on assessment. All right. Case assessment or speech assessment would include a case history interview and or questionnaire for the parents, an oral mechanism screening, right? So we're going to look at the child's tongue, their lips, their hard palate, their soft palate, how well are they breathing, all that good stuff. We're going to do a hearing screening. Gosh, so important with these little ones, right? Are you able to hear me, right? Your speech might in fact be fine. It's just that you can't hear what we're saying. We also need a language sample and a screening eval, right? So we're going to go and we're going to play, and we're going to play with doll houses, and we're going to play with trucks, and we're going to play with Legos, and we're going to play with all these things and try to get, a nice language sample and see how much you can say. and then an overall speech assessment, and we'll talk about that in a second, and an analysis of the speech performance. All right, speech assessment designed to achieve 6 things. We want to know the child's general developmental background, including family characteristics, right? So when did the child start babbling? When did they say their first word? Also, is there a family history of speech and language disorders, of hearing disorders, of attention deficit disorder? Characterize the status of auditory and oral structures and functions. We want to characterize current phonological and language performance, right? So I'm going to make a list of every sound that child makes during that evaluation and every word they're able to say. Characterize the nature and severity of the speech sound disorder, determine the prognosis for phonological outcomes, and determine the course of intervention. All right, case history, interview, questionnaire enables the clinician to understand the child's communication from the family's point of view, right? So what does the family feel like is going on? What do they think is the most important thing? Also, are there any cultural factors going on that may influence the assessment? So are we not aware that, at home, maybe the kids are speaking Polish at home? And maybe that's, maybe they're adding in some Polish, and that's why the daycare teacher's like, I can't understand this kid. Well, he's actually doing fantastic. He's bilingual. He's just mixing in some Polish language in with his English language. Develop familiarity with the family that can facilitate the assessment process, right? So getting to know the family a little bit, seeing, what goes on, and that's going to help the whole process. Understand family variables that may complicate or complement the child's speech development, right? So what goes on in the child's house? Are they, do they have the TV on nonstop? Are they reading to the kid every night? Are there lots of kids and grandparents and cousins all living in the same house, and the child has no chance to speak? Is there almost nobody in the house? The child's just home with mom, and mom's depressed, and mom sleeps all day, and the kid just kind of, does his own thing all day until dad comes home, or who knows what. So, right, what's going on in the house that either is really, wow, you guys are doing amazing things, you're doing the very best you can do, or wow, maybe there's some things that we can change in the environment, and that might really help. All right, oral mechanism screening, a careful examination of the structures and functioning of the speech mechanism. We've got lips, teeth, tongue, hard palate, soft palate, right? So can you make a kissing sound? Can you move your tongue? Can you move your tongue back and forth, up and down, right? Open and close your mouth. Bring your teeth together, right? Say ah, say right? Can we have that nasal sound? Hearing screening, we're going to complete that to rule out the possibility that a hearing impairment is the cause of speech difficulties. We're just going to give a really quick, right? Do you hear this sound? If yes, raise your hand. And also just asking the parents, do you feel like he can hear you? When you call his name, does he turn around? If not, maybe he's just not paying attention or is really interested in what he's doing, or right, maybe he really can't hear what you're saying. SLP should assess expressive and receptive language skills as well as phonological awareness skills. Again, we're going to get a good language sample. So I'm going to get as much speech as I can out of a child, as much language, and I'm going to write down every word they say, every sentence they say. What's this child's language ability? Are they at the same level as their peers? Maybe the child's hard to understand, but boy, he seems to have a lot of words, seems to be interested in things, right? Or maybe the child says almost nothing, and there's few things they say you can't understand. So that's really, language is a really important part of this. And kids that have a speech sound disorder are going to be more likely to have a language disorder, and vice versa. Speech assessment, we're going to do production of sounds and single words and connected speech. We're going to usually use the Golden and Fristo to do that. We'll talk about that in a second. We're also going to talk about stimulability, ability to correctly imitate an incorrect sound with cues, right? So if for the S sound, the child makes a t, sound all the time. So the word sound might be town, town for sound, or stop's going to be top, or seven's going to be tebben, right? We're going to say, oh, can you make a snake sound? Go, make a snake sound, right? If they're able to do that, they're stimulable to make the S sound. So maybe the child can't put that into his speech yet, but he's able to go like and make a good snake sound. I know he has that S in his little body, and that it's just, it'll be quick then to get that into speech. But if I tell him to make that S sound and that snake sound, and he goes, it's like, uh-oh, this is going to take longer because he's not stimulable to be able to make that sound, even all by itself when we're kind of playing around with sounds. All right, also consistency, right? Maybe a child's able to make the S sound at the beginning of a word, but not at the end of the word. Well, again, it's in his little body. He's already making it in words at the beginning of a word. Then it's not going to be a big deal to get it at the end of the word, right? But if it never appears at all, that's a problem. So if it's inconsistent, he gets it sometimes and not others, that's actually a good thing. If it's consistently not there, that's going to probably take longer in therapy. Also, how severe is the speech sound disorder, either through the score in a test or percent consonants correct. So, out of 100 consonants, how many times does he make the true adult-like consonant, or how many times does he make sort of his own consonant where he substitutes a t for an s and a d for a g? All right. The most popular articulatory test is the Goldman-Fristow test of articulation 2. It's just a bunch of pictures. So it's a picture of a house, and a picture of a window, and a picture of a carrot, and a picture of a rabbit, and a picture of all these things, and it encompasses all the sounds, all the consonants in the English language. And is the child able to, how many of those do they get correct, or like an adult would say, versus how many do they not get correct? Also, we've got phonological pattern testing, right? So remember, the phonological is that there's a pattern, there's a rule that's missing, and you can actually take how they do on the Goldman-Fristow and you can plug that into another test called the Conn-Lewis, and it'll say, oh, he missed all his K's and G's, he turned into T's and D's, so he's fronting. He's taking sounds that should be produced in the back of his mouth with the velar, that k, g, and he's going d, t, near the front of his mouth, right? So he's fronting is what his phonological process will be. So it actually tells you right there, or really, if you know what you're doing, you can just use the Goldman-Fristow and figure out the phonological process on your own. Analysis of speech performance, the key outcomes of the assessment. An analysis of the data and speech and language samples to identify predominant error patterns. Make a differential diagnosis, right? Is this just an articulation disorder? Maybe he's having trouble with R's and S's and nothing else, right? It's not a pattern, it's not a rule. He's just not putting his tongue in the right place, all right? Or is it a phonological disorder where maybe he's not putting endings on words, maybe he's fronting all of the sounds, maybe he's stopping all the sounds, right? Or maybe it's a speech motor disorder like apraxia, where he's going to have a really difficult time planning what he's saying. We're then going to, through the diagnosis, we're going to determine appropriate treatment targets and design an effective intervention plan. All right, and there are a couple ways to analyze the speech performance. One is a relational analysis, and this provides a description of the child's sound errors in relation to adult standard in a one-on-one comparison for each of the child, right? So, all right, he made a T when, the adult version would be an S. He made a D when the adult version would be a G, right? So it's kind of an error analysis. Here's what he did, here's what he should have done, here's what's going on. And then there's sort of an independent analysis. So we're going to write down every sound the child's able to make, and we're then going to talk about, all right, this is where, instead of, individual sounds, we're going to say, all right, he takes K's and G's and maybe S's and turns those all into a D sound, into D, right? So we're just going to look at that one child. We're not going to look at individual errors and how many errors they made. We're going to then just look at the child and say, here are all the sounds he's able to make. Here are the sounds he can't make. And the sounds that he can't make, what sound does he make instead? Okay. So it includes a description of the child's phonetic inventory and phonotactic pattern. So what's the pattern, right? On those long sounds, those S's, those F's, right? Is he stopping all those? What's going on? All right. In your book, it talks a little bit about oral motor exercises. That was a big fad for a while, where you'd have kids, blow out of a straw or move their tongue side to side, sort of to make the idea was to make your muscles stronger. But a speech sound disorder has nothing to do with strong muscles. Well, I shouldn't say never, but almost never is about the, muscle weakness. It's really about either not understanding rules or just putting your tongue in the wrong place. And doing non-speech oral motor exercises has been pretty well proven to be not useful. And the intent of evidence-based practice is to promote the adoption of effective protocols, delay the adoption of unproven protocols, and to prevent the adoption of ineffective interventions, right? So if we know something doesn't work, don't use it. If we're not sure things work yet, you can try it out, but we're not going to promote it. We're only going to promote the things that we know work. But again, there's nothing that says that we as speech pathologists can't try new things and can't try things that we think might be helpful, but the field just isn't going to promote anything that it doesn't know is effective. And then the idea that speech therapy works. So there are lots of different therapies for speech sound disorders. None of them have ever been shown to really be better than any others. Now, things like oral motor exercises have been shown to be worse than the speech sound disorder therapies, but all the speech sound therapies, they work. They're better than no therapy, but it depends on the child, what the child needs and does, and it depends on what the speech therapist is really good at using. Those two factors are going to tell what works and what doesn't. All right, we've got a couple approaches. We're going to talk about this. There's the contrastive approaches, the stimulability approach, the core vocabulary approach, and the metaphonological approach. Oh, and for childhood practice of speech, the DTTC, the dynamic, temporal, and tactic cueing approach. All right, homonymy and an unintelligible speech, contrastive approaches, right? So homonymy, right, is where, so if I have a child and he says D for S, for F, for T, for P, right? He might say D. Well, that word then could be fee, it could be P, it could be C, it could be lots of different words, right? He's making them all the same because he's collapsing a lot of sounds into one sound. And so contrastive approaches are, number one, a minimal pair approach where, all right, if I'm using that D for everything, well, let's see if we can get some B's out of that D, right? And the B sound is voiced, it's a stop. The D sound is D is voiced, it's a stop. B, one's produced with the lips, bilabial, boy. One's produced with the tongue, D, right? So it's a minimal pair because it's only differs by one thing. They're both voiced, they're both stops. The only way they differ is place. So I'm going to play with, can we, if we just have a D, let's also get a B. Now, that is sort of, then the opposite way of thinking that really is, I think of multiple opposites and complexity approaches similarly, where they're going to look at, let's explode this. So if everything is a D, is that's like the only constant he's got, let's do the complete opposite of that. Let's do something unvoiced. Let's do something that's a fricative, that's long, and let's do something that is a, so D. Let's do something that's produced in a different place. So let's go fee. Let's work on the F sound. So fee, few, for. Let's just do F, 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 and maybe we'll try V, and we'll try just sounds that are completely different. Because if he can get F, well, now he's got fricatives. Now he's got, right, an alveolar. Now he's got unvoiced sounds, right? I've just done the complete opposite. So it's sort of the very different. You can go with a minimal pair, doing something very similar, but just one step, one thing different, or you can do multiple opposites or something more complex where you're doing something the complete opposite. And the idea is if he can get that, if he can get the complete opposite, then he can get sort of all the sounds in the middle and that they all come faster. And we're going to decide by the nature of the contrast, the size of the contrast, and how homonymy is addressed. All right, so, and again, it really just depends on the therapist. I haven't done speech sound disorder therapy in a little while, but I used to like the multiple opposites where if we can get a completely different sound, that's going to open up so many things, right? If we can take a child that just has the D sound and the B, maybe they just have D and B, and we're going to introduce, a fricative, a long sound, and then, wow, but now we've got all kinds of things. But it depends on the child, depends on the therapist. Limited phonetic inventory and poor stimulability. All right, so again, if we have a child who's pretty severe and isn't stimulable, right, you're playing around with sounds and they can't do any of it. We're going to have fun. We're going to take turns. And the goal is really stimulability. So can you make sounds, right? So we're going to go snake sounds. We're going to make pirate sound, R. Monster sound, right? Whatever. We're going to try so many different things, and we're going to go back and forth and play and play and play, right? So, R, and just all kind of different sounds. So not even words. Let's just play around and make sounds and see if we can start to make some sounds. And once we can make the sounds by themselves, then we're going to start working out. So, this should only work for a little while. Once you get a sound, then maybe you go to the maximal opposition therapy. But you'd start out with the stimulable approach, which makes a lot of sense, I think. All right, for inconsistent speak errors, you can do the core vocabulary approach. The goal is to teach how to plan the sequence of phonemes for a specific vocabulary word so the words produce consistently. All right, so kids that have inconsistent errors, sometimes they get it right, sometimes they get it wrong. All right, let's work on like the 50 words that they're going to say the most. And we're going to drill those words and drill those words and drill those words and drill those words. So at least 150 responses in a 30-minute session. Really, if you know what you're doing, you could get 150 responses, and you could only need to have therapy for 15 minutes and just drill and drill and drill and drill and drill and drill and drill, and then we're done. And try to get those words, and once they get those words that they say all the time and they get them strong, and I'll bet those 50 words have all different kinds of sounds in them, so that we're going to see a lot of carryover. So that can be a nice way to go with kids that kind of have the sounds but just need a little refinement. If you can do some hard drill on the 50 words they say the most, boom, you can knock that, a lot of the speech sound disorder right out. Phonological awareness deficits, a metaphonological approach. This is a conscious awareness of the structure of words and the sounds that make up the words, right? So phonological awareness, we're going to increase awareness of word forms and how child speech differs from the adult target. All right, so this is what you're saying, this is what I hear. Do you hear the difference? I hear the difference. You said this, but you meant this. Sorry. So really making them understand what a word is, what a sound is, and how, you know, the sounds actually make up the meaning of that word. So this can be a nice way to do this. It's nice to actually mix in phonological awareness even with other kinds of therapies. Last one, for childhood apraxia of speech, which is usually your kids who are most severe, dynamic, temporal, and tactile cueing, we're going to use a hierarchy of temporal delay. So from the beginning, right, we're going to say words at the same time and we're going to stretch them out. So when we're going to start, maybe we're going to start with something we know they can already say. So maybe they can say day. So I'm going to say day, day, and we're going to say it together. And then I'll say day, and then have the child say day after me. And then I'll say day and hold up a stop sign. And then when I hold up my green light, they then can say day. So hierarchy of temporal delay, so there's going to be timing involved. So, and then once they can do that with words they can already say, then we'll start doing it with sounds and words that they have trouble with. Emphasis on tactile, so touching, right? So I'm going to touch my lips and say, I'm going to touch my lips and go, duh, duh, right? So to touch your lips and say "t" and feel that air explosion on that stop sound, right? So that's a tactile. And then visual cueing, right? I'm gonna have the child really watch me and watch my face, watch my lips, watch my mouth, watch my tongue while I'm talking. Have them try to do that, even without making sound, but just can they do that? Can they maybe mimic me while I'm talking? And also incorporation of motor learning principles. So again, we're going to drill a lot. One good thing that came out of DTTC, I think, is that they found that doing something really hard for maybe 10 minutes a day and doing that 4 or 5 days a week, you get a lot more success rather than doing it for 30 minutes twice a week. So if you can drill, you're right, you can pull a child out of maybe homeroom for 10 minutes and just boom, 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 get a huge amount of drill going, you know, and really working on tactile, feeling, you know, having the child feel his own lips, really watching you, really making sounds. You can get, again, some good things going. Childhood apraxia speech often takes a really long time and you see slow gains, but boy, when you make them and the child realizes that, you know, he can be understood a little bit better, it makes his life and his parents' life so much easier, right? Which gets us to caregiver perspectives. Again, speech sound disorders are the most common communication concern among parents and teachers of preschool children. So parents and teachers are often worried they can't understand the kids. They report that their children get frustrated. They start having behavioral issues because they get frustrated, right? Often as a speech therapist, you don't necessarily see this, right? They come in, you drill, you work, you have fun, maybe you eat, maybe, you know, you're giving them rewards for talking well and they're nailing it, and you have no idea that at home the child, you know, the parents can't understand the child's crying, the child's just getting angry and slamming doors, right? So it's so important to know what's going on. And that children are often, you know, actually even less worried about their own speech. They're worried that my mom can't understand me, or my best, you know, my friends can't understand what I'm saying, and they cry. And right, so realizing that there is, you know, there's an emotional side to these disorders as well. I think I kind of said this, the parents are also concerned about the behavior of their kids because their kids get frustrated. Goals and targets, what's targeted is as important as how it's targeted, right? So if you can pick the right things to work on, sometimes that's important as how you target them. 3 approaches to target selection. One is developmental approach, right? So I'm going to take the speech sounds that should be acquired first, right? He's got that one, he's got that one. Oh, he doesn't have the third speech sound that he's supposed to get, so let's work on that one first. All right. There's also the complexity approach, which is kind of like what we were talking about before with multiple opposition therapy, where you work on some hard sounds. So let's try R's and L's and S's and K's and G's and THs. Let's work on the hard stuff, and maybe they'll then be able to do the easy stuff. Or there's also just a systemic approach where, all right, here's what the child's able to say, and here's what makes his talking the hardest, and here's what I think would be the easiest thing for him to learn next. So with the systemic, you're really just saying, here's what I think would work best within the child. It's not strictly, okay, from a developmental standpoint, he should have this sound already. That should be the earliest sound he should have gotten. Let's go ahead and work on that first. The complexity approach, let's work on the hardest sound. A systemic approach is more, let's work on what this child needs right now and what I think they can be successful in right now. Last thing, discharge, length of time. All right, so the earlier you get to kids, usually the easier things are. Obviously, the more mild things are, usually the quicker things go, and the type of intervention adopted. And also, like I said, if you work 10 minutes a day for 4 days a week, you often get better results and quicker results than if you do 30 minutes twice a week. So the type of intervention, how it's carried out, can be important for that too. And that is it. Thank you very much. And that is the end of chapter 9.